Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallis.
It's Saturday, January 27th. Hello and welcome to The View on GU. Thank you so much for joining us, ladies and gentlemen. I'm Ali Khan Lalani. I'm joined by my co-host, Christopher Wallis. Chris, how are you doing? Last day of GU ASCO. How are you feeling?
We made it through, man. It's been a busy trip, but lots of great data, and I'm glad to be here with you.
Yeah, absolutely. It's been an awesome meeting, and we're going to be summarizing day 3, which is essentially the renal cancer day and some rare cancers. Let's go through a quick rundown for what our listeners and viewers can expect to hear today. We're going to break this down into adjuvant setting. This is a really multi-D topic. In kidney cancer, we saw some data for patients who have had nephrectomies and treatments that can be offered to them. We did get some updates about long-term follow-up for first-line treatment for advanced disease and also novel options for patients with pre-treated disease, a little bit of update there. And then we'll talk a bit about how to give immunotherapy, different ways of delivering that, and some innovative, oral session on this, and really hopefully for a foray of more to come. So let's start with the adjuvant space. Chris, as a urologist, you've seen a lot in this setting over the years. Take us through the first abstract that was presented.
Absolutely. So, adjuvant therapy, we were talking about it yesterday in the bladder and urothelial space. And this is a great example of where multi-D care is just so critical for our cancer patients. So, adjuvant therapy in kidney cancer has been a long road, I would say. Today we heard 17 RCTs, 12,000 patients. We're talking many, many decades of work to get here. And now we've got, a really body of evidence to look at. And so our first talk we had today is come from Dr. Motzer, looking at the Checkmate 914 data and really the Part B subset of this trial. So really the overall landscape of this trial is to look at IO with Nivo and Ipi in the adjuvant space. Now the Part B gets a little more complicated. It's trying to do a component analysis of Nivo Ipi together versus just Nivo itself. But this is a building block upon our foundation of Part A, which has already been reported out. So just to sort of lay the groundwork here, both Part A and Part B of 914 are adjuvant interventions in patients who have intermediate to high risk resected kidney cancer. So what does that mean? So we're talking about here PT2As, if they're grade 3 or grade 4, all PT2Bs, PT2C, node positives, but importantly not resected metastatic patients. So not that M1 NED subset that we've seen in some other trials. And in that context, Part A, which has already been reported, compared Nivo Ipi for about 6 months, 5.5 months or so, to observation and didn't find a benefit. This Part B was pre-specified as a 3-way randomization in a 2-to-1-to-1 pattern to either Nivo monotherapy, placebo, or the combination of Nivo Ipi. And I think really the interesting data here comes from the Nivo mono arm, although Dr. Motzer did talk to us a little bit about the Nivo Ipi combo. And so just a few thoughts in general. First, the study is designed with relatively low power. So they're only giving themselves 60% power to find a hazard ratio of 0.68 to begin with. Mm-hmm. So we're already starting with a bit of an underpowered study, even though they've got 800 patients on the trial. And I think that's important when we start to think about what we can expect from outcomes. So, we talked about the patient inclusion criteria, but it's also important not to just understand who could get on the trial, but who did get on the trial. So this is, 95% radical nephrectomies, a handful of scattered partials. About 80% of this cohort is PT3. So we did talk about an enrichment potentially for that lower risk subset, the PT2A high grades, PT2Bs, but the majority of these patients are really PT3s, and a relatively low representation of sarcomatoid here, about 5%. And so when we look at the outcomes, so we get about 5.5 months of therapy, and then we're following these patients out for disease-free survival events. and we're seeing no significant benefit to the nivo mono arm. So at 18 months, we're talking about 78 versus 75% disease-free survival, hazard ratio of like 0.87, not statistically significant. There is obviously subgroup analyses that immediately come out of any analysis like this. And so the forest plot that we're used to popped up in Dr. Motzer's talk. And, I think there is a little bit of suggestion that in the sarcomatoid patients and potentially in those with higher PD-L1 expression over 1%, maybe there's a bit of action there, but it's hard to go digging in a negative trial sometimes. And I think at the end of the day, this trial is not going to bring a new treatment to our clinics.
Yeah.
How do you see it from the MedOnc perspective?
Yeah, no, I think it's an important trial to do. We had lots of hopes given nivo-ipi works for really incurable palliative intent treatment in the stage 4 setting, and we're going to talk a little bit about an update on that study. But in the adjuvant setting, we were hoping to see benefit. We didn't see it there. There's questions about the body needing some sort of tumor or tumor antigen to benefit from combination immunotherapy. Are there risks of side effects that might temper the expected benefit? But I agree with you. Nivo-ipi and then the part B of nivo alone are not standard of care, but very important studies to do. We had this in Canada, and I think it was important to test it. So, I think it is interesting. The obvious question becomes, what do we make about the landscape in general? We have a negative atezolizumab trial, but importantly, we have a positive pembrolizumab trial for DFS, and that kind of dovetails nicely into the next abstract we got, which is updates from Keynote 564. Just to remind everyone, I know our viewers and listeners probably know, but this was a large randomized phase 3 trial, nearly 1,000 patients getting 1 year of pembrolizumab, so not 6 months of treatment in the Checkmate trial versus placebo for 1 year. And we already knew there was a DFS benefit. This has been US FDA, Health Canada approved, reimbursed in Canada, and available across most provinces. And so this has already been in the water for our patients. But importantly, what we saw today, and I think it's important to just step back and realize a really landmark day for kidney cancer. As you mentioned, we got to see overall survival data.
That's the first time ever, right? We were talking about 17 RCTs before in this space. None have ever shown OS benefit.
Yeah, no, you're absolutely right. Now with a really median kind of follow-up in the 57-month range, right? So we're talking a fair bit of time out where we get landmarks at 24, 36, and 48 months. We can now report that there is a survival benefit studied in Keynote 564, a hazard ratio of 0.62 with a p-value of 0.002, which met the boundary for statistical significance in an adjuvant study for kidney cancer. And for folks interested, and I think it does matter because these patients are doing well, at the 4-year time point in this trial, 86% were found to be, really alive in the survival analysis on the control arm, but the intervention arm had benefits in the 91% range. So there's a life-prolonging component to this study. First time we've seen that. Both DFS and OS improved. And so I think, this really is an important trial. We were looking at curves for the, different risk categories. We didn't see those curves to follow them and look at absolute differences, but we did get hazard ratios. So for the intermediate high risk, which again is the majority of the patients in this study, hazard ratio for survival, 0.59. For the high risk patient, 0.78, and for M1 NED, 0.51. Again, some of these smaller groups have confidence intervals that cross 1, but the real large proportion of patients were found to have a survival benefit. And we did get an update on the DFS at this time point. Again, largely preserved. These curves are separate. So at 48 months, the chance of the patient being disease-free and alive is improved by about 8% for all patients, a hazard ratio of 0.72 for DFS. And I think there's going to be, we're hot off the press here. We're recording this literally right after the oral session. There's going to be some time to absorb this data, digest it. But I think on quick reflections, what we did see, and was part of the discussion after, was we're talking about survival, lifespan for patients, necessarily needs to think about what treatments do they get after. And so at least on this study, as currently reported, for patients that did recur, so 161 in the pembrolizumab arm, 210-ish on the placebo arm, about 80% of patients, let's say roughly 80% in both arms, got some sort of systemic or some sort of subsequent therapy. Okay. Within that, there was a proportion, about 80%, 84%, that got some sort of anti-cancer drug therapy, because there are patients that could have gotten surgery, who could have gotten focal radiation, SBRT. We have very good multi-D care for our patients. But I think on the pembrolizumab arm, it's fair that there was about 41% of that proportion, right? So really 42 out of the total 161 that got anti-PD-L1 therapy in the pembrolizumab arm, but 94 of those patients, so again, 92% of the 80 that got VEGF TKI. And that's a lot of the questions is, if you've had pembrolizumab, what drug would you get next? We didn't see the time points of when these drugs were intervened with, how quickly after their adjuvant therapy. And the placebo arm, again, with the caveats of who got subsequent and then how many people got anti-cancer therapy, there were about 101 patients who got PD-1 therapy out of 210 who recurred. So there becomes a question about, could these patients have been eligible for more, or were they doing so well that they could have gotten focal treatment and then needed immunotherapy later? But with those caveats, and I think very important discussion points, good updated data, fractions of patients who did get treatment. At this point, we now have a life-prolonging therapy. I'll just make a final plug for what's the kind of cost of doing business to the patient in terms of side effects. We have largely counseled patients that about 1 in 5 have a risk of grade 3 or more treatment-related adverse event that's preserved, and about 1 in 10 have a chance for needing high-dose steroids in a curative intent setting. And again, the control arm does behave quite well in certain risk groups. So, to me, this is where the lay of the land is. We have an approved agent. We have, at least in our center, been discussing these patients and having them hear about DFS. And now we can talk a little bit about overall survival. Chris, from your vantage point, what had you been doing from a uro-oncology perspective, and how do you think this data will be interpreted by the uro-onc community, again, on first blush?
Absolutely. So I think the first thing is, my read of the landscape is that there's a lot of heterogeneity. There's a lot of variation in practice here, both from a uro-onc perspective and also a med-onc perspective. Different people see the data in a different way. And so, for me, I don't like to be a gatekeeper holding people away from something that they may benefit from. And I really am of the perspective that patients deserve to hear about these treatments. And so, I guess it's about 1.5 years now that we've had approval. I was pretty early on, very aggressive, I would say, about referring. Now, I would say that many of my patients who have referred haven't ended up on therapy. But when you see the path reports come back, you're seeing T3 disease, and that's a trigger for me. And I'm sending nearly all, I would say, of those patients off to at least have a conversation with a medical oncologist. It doesn't obligate the patient to go on to 1 year of therapy, but I certainly think that we don't want to, preclude that conversation or that possibility. And so, there's some logistic considerations on these patients. They need to be restaged after surgery. And so when I'm seeing them pre-op and I'm worried about T3 disease, particularly, you see a bit of a vein thrombus, or it's that high-risk characteristic, I'm already lining up their post-op scans so that, we can navigate the system and get them through their surgical recovery, rescans, path reviews, medical appointments, and on to therapy in that first 12-week window. It's a process you have to be sort of a little bit proactive about trying to navigate.
No, and I think that's a great, practical guide as to what you're doing in your clinic, and certainly at our center. We've had a great relationship with our uro-oncologists who have been seeing these patients, and again, needing a timely path report, having a timely conversation, referring with appropriate imaging where necessary, and then ensuring medical oncology is seeing these patients to discuss adjuvant therapy, which is a change management principle in kidney cancer. When you look at the last 20 years, but is being done in breast cancer, is being done in colon cancer. And so I think, the GU world needs to adapt. We need to make sure our centers are ready. We need to make sure from a human resource perspective, we're ready. And again, I think we need to be clear, today, Saturday, just fresh off this data, there'll be some digestion and we'll all reflect on this. But there are going to be comments about the differences in patient populations. Are the drugs really different? Does the timing really matter? When you look at the curves, is it likely 6 months was the answer on all this? I doubt it. There's probably pebbles or contributions of little pieces along the way that explain the differences. But the reality is as you've said, there's a life-prolonging therapy, a benefit for DFS for an approved agent that's reimbursed in many places. I like your take that we should have patients hear about it, and then it's their choice, right? It might be a coin toss, but at least they've been informed, and we've advocated for them in the right way. So I think more to come. I think we could talk a lot more about the peri-op space in kidney cancer. We may need to do it in a future podcast, but I think this is a great summary so far.
Yeah, I think we will be talking a lot more about this, but there's more data that came out today. I would say no real breakthroughs in the first-line metastatic space, but maybe some updates more than breakthroughs.
Yeah, very briefly in the rapid oral session, lots of great presentations, I think, to be honest. But just to point out, there was a clear study update about, we've seen this trial recently, largely preserved outcomes, but some analysis by responses and some subgroups. I think we had the Checkmate 9ER 55-month follow-up. This is the large randomized trial of nivolumab and cabozantinib dosed at 40 milligrams against sunitinib. And we got a chance to see really, again, improved and preserved PFS, survival now reaching 46 months in the ITT population, and good responses with CR rates in the 13%. Of interest, the favorable risk was reported, and these patients benefit from combination treatment in short-term endpoints. Response we see is better. PFS we see is better, 21 versus 12 in this study. OS, I have to say, I think we're starting to see a theme. The IO TKIs versus TKIs, these patients, we're not seeing a difference, or maybe there's been, a hazard ratio drifting above 1. But I don't think that's a punitive comment of 9ER. I think that's just the way the IO TKIs have largely played out for overall survival for good risk. Mm-hmm. Realizing the short-term endpoints have benefited. And the reason I think that's an important conversation is I was quite curious to see the long-term follow-up for nivo-ipi. So again, this is a trial that's been read out for some time now. Nivo-ipi for up to 4 doses, followed by maintenance nivolumab versus sunitinib, and they had median follow-up of 8 years. Okay, so that's very, very cool to have a first-line trial in kidney cancer have 8 years. I remember trying to put patients on study in my residency, so to think there's 8 years follow-up of this readout is pretty cool. But again, for a trial largely alpha designed for the intermediate poor risk, we still saw improvements with a good hazard ratio of roughly 0.69, 0.7, nearly 4 years of overall survival for the intermediate poor risk patient. But I was interested about favorable risk. There was always a suspicion that maybe over the long haul, will these patients do better? And I think to at least see for these patients having a favorable risk disease, a hazard ratio that started above 1 and is now drifted into the 0.82 range with medians. Again, think about this, Chris. Sunitinib at 66 months, which 5 years plus for good risk on a TKI. We have patients in our clinic that have been doing that for years prior to immunotherapy. But to have good risk with nivo-ipi having an overall survival benefit reported now with a median of 77 months, that is a clear median improvement. The totality of the curve when you follow it has a hazard ratio of 0.82. Again, confidence interval crosses 1, not the main IMDC risk group with statistical design to answer this question. But I think there's been a drift now to show that perhaps in an ideal world, would it be nice to have nivo-ipi across risk groups, realizing the labeled indication, and we want to be clear about that. But seeing this maturing data is pretty cool.
Well, and I think it's interesting because we talked about when you're thinking about choosing combo therapies, often the thought process of trying to give that TKI is about getting, rapid disease control. And so maybe these favorable risk patients actually don't need that rapid disease control. And as you're alluding to, may get that really long-term benefit if we go this route.
Yeah. And again, it's how do you pick that patient? Knowing up front, it's a lot of conditional survival analysis, right? And obviously we're making these comments in the context that in Canada and many jurisdictions, nivo-ipi is approved for intermediate poor risk. But I think this is the importance of having long-term follow-up. When you're leveraging CTLA-4 with the way it works, the short-term endpoints, we need to be open about. But these longer term endpoints as they follow. I really applaud the group for showing such long term follow-up. I would ideally hope to have long-term follow-up for the IO-TKI groups, but to see that striking benefit in the good risk population, I am curious to see how people digest this data. And if you told me I could rewrite access, I would like to be able to offer this type of combination to good risk patient. But anyways, that's the first line systemic update. Just a quick plug that the pre-treated population did get an update for the belzutifan trial, really looking at the quality of life data. So I would say efficacy we saw readout as a hazard ratio that benefited belzutifan versus comparator of everolimus, but the quality of life I think was delved into a little bit. And I think really the take-home message is that this is a tolerated medication. And I think there's a larger conversation about if we like our quality of life tools in general in solid tumor oncology in the metastatic setting, given how it might have been developed. But these patients tolerated the treatment well, and it's nice to see that time to deterioration was improved with a new mechanism of action. I think it'd be nice to have access to this drug for our patients in Canada, and really in many jurisdictions. And again, the longer play, I think, is how will the studies that leverage this earlier on in lines of therapy, in subsequent line, and then now even in the first line. I think this is at least reassuring. We're getting phase 3 readouts of side effects and quality of life and clinical outcomes, and then as we move forward, we'll always have the base of some of these important readouts from a phase 3 trial, which I think for regulatory authorities might be informative.
Absolutely, and I think maybe I'm interested in your thoughts. Where's mTOR headed? Another head-to-head study where we maybe are seeing an alternative to an mTOR inhibitor.
I think probably for most patients with kidney cancer, mTOR inhibitors, again, different jurisdictions have different access points, but I think they've largely fallen as a non-approved or reimbursed option in light of having now multiple lines of therapy. So in Canada, we have something called a CADITH provisional or rapid or updated algorithm that comes out, and mTOR inhibitors are not on that. Though, in fairness, lenvatinib and everolimus is an approved combination. It's not reimbursed in some jurisdictions that might require lenvatinib to be given with everolimus in the subsequent line setting. But obviously, with lenvatinib moving earlier on, I think it does leave everolimus, I think, as an older agent now. I think this won't be part of control arms for future trials. I think it's largely not used. As a researcher, I'm curious about TSC1/2 alterations when I get that on genomics. Could I use an mTOR inhibition there? But I think largely these are exceptional patients, and mostly I think mTOR inhibition is really out of systemic trials. We've seen the adjuvant mTOR readout, so I think we've kind of really settled and moved on. But again, it just shows the remarkable progress we've made.
Absolutely. And so I think there was one other really interesting abstract that we saw in the oral session. And this is maybe not a new drug, but a new way to give drug. And so as we get more and more patients who are needing immunotherapy and there's new indications, we're getting a bit of a crunch and a bit of a health system issue. And so we saw some great data from the Checkmate 67T study looking at maybe a different way to give Nemo. So you want to walk us through that?
Yeah, I'm glad we were trying to fit in a little bit of time on this, because the context here is nivolumab had initially been approved in pre-treated kidney cancer, so folks that would have had TKIs and then had access to Nivo, which is life prolonging. This study looked at evaluating a different way of giving it subcutaneously at a dose of 1,200 milligrams every 4 weeks. And it was really compared to nivolumab given every 2 weeks. And really the primary endpoints or outcomes of interest here was looking at concentrations really averaged at 28 days. So meaning 1 sub-Q injection versus 2 of the IVs, which are Q2 weeks. And then also looking at what's called kind of a steady state dose. And I think really when you're looking at things like this, you're trying to hedge for non-inferiority generally. You're not generally trying to show superiority with alternate formulations. And for non-inferiority, some of the bounds of the lower limit of confidence intervals were set at 0.8 for some of these, concentration measurements. And what I found interesting, and I think we both talked about this, off camera, is that, setting that lower confidence interval border at 0.8 and then seeing these ratios now in the 2.0 range for the 28-day average dose, and 1.7 for the kind of minimal steady state, really met that it was non-inferior, and it almost asked a question when we look at Cmax and other endpoints that might be coming out. Is this a way of not only giving effective drug, but is there something about how much can actually be delivered subcutaneously? This was 1,200 milligrams. Is that the right dose? If so, patients are clearly getting nivolumab, at least from a concentration-wise, very effectively by subcutaneously. And Chris, I think this has lots of interesting healthcare implications. I will just remind our viewers and listeners that, in general, if there's 30 minutes to give IV nivolumab at a Q2-week dosing in a chair time in a cancer center, and you can drop that down to 5 minutes or less by a subcutaneous
and maybe
injection.
Not even in the cancer center.
Yeah, I mean, think about what we can talk about. Again, not to breeze too much through the data, but again, this was a pre-treated population. So again, I don't think that's going to be largely the future of kidney cancer. But what do you take on this from a policy perspective or a upstream healthcare system level to now think that maybe we have a non-inferior or a potentially appropriate way of delivering nivolumab for kidney cancer patients?
Well, I mean, I think, it's a kidney cancer trial, but we can also even think beyond kidney cancer.
100%.
Where we have established care pathways to give sub-Q IM injections that don't involve physician offices, right? So we have home injection programs for ADT and prostate cancer. And certainly this opens up the possibility of a way to deliver therapy that's less burdensome to the patient, less burdensome on the healthcare system. And we can, shift care out into the community potentially, right? We can reduce that travel time, the parking costs, the chair time for the patients, and really, reduce that family and patient burden, and really make, care more accessible.
Yeah, I like the theoretical kind of upstream implications are great. I mean, I think even, regardless of your own individual beliefs, but the impact or climate care in cancer, which to me, I think is a very interesting thing I'm curious about. But, if patients can not need to drive in, given we know by zip code, whether it's US or postal code in Canada, the distance to cancer centers is real. It can affect care, but is it possible to deliver this at home or outside of a busy medical oncology clinic or outside of the infusion center? I think there might be gains there. And again, it needs to be thoughtfully done. If patients are getting doublet or triplet, does it make sense to have one component at home? Maybe not, but can it be delivered in different ways if it is monotherapy or patients are on a maintenance treatment? There's lots of options here. So I think, at least this first foray of showing concentration levels in a non-inferiority setting was interested in, and I think the mind turns about what we can do for our patients in clinic, but for the hospital level, upstream healthcare level, as long as it's safe. And I actually think now that the arms race will not only be about immunotherapy and new checkpoint inhibitors, I think it'll be ways of giving it. Mm-hmm. And so I think there's going to be lots of long-term implications of this. I will just wrap up that abstract by saying, they did comment on some things like response. Largely this is a small concentration-seeking study on non-inferiority, so I would say it's no worse. Maybe it is a bit better. Arguably, there's a little bit more concentration in the body. I think antidrug antibodies, I think are going to be really interesting to see at baseline versus acquired on. Do you pulse off of the sub-Q to go IV? These are all cool biomarker stuff in the future. But I think the take home for our listeners and viewers is, hey, there's different ways of giving immunotherapy, and we're, at least in kidney cancer, maybe the GU community getting there. Mm-hmm. So it's pretty cool.
Absolutely. And so, I think as we try and put all of this together, today we saw data that sort of reaffirms things we already know, gives us absolutely new data that, has a completely, I would argue, paradigm changing implication. And then we have a way to the future, maybe, of things that are yet to come. And the whole spectrum, I think, really gives us hope for the quality of cancer care we can deliver for our patients with kidney cancer.
Yeah, and I know we're wrapping, Chris, but you and I have mentioned this, and I think it's really important. We just want to thank, this is day 3. We're wrapping up. Chris, you're literally about to catch your flight. So by the time our viewers see this, we should be back in Canada. But thank you to everyone who's been really supportive, in person, on messages, just giving us the good vibes and positive feel that that there could be a need, and to all of you listening and watching. It's our launch, really, our launch week, and it's been awesome doing this with you. I mean, we could talk forever, and we do off camera anyways, but it's been a lot of fun doing this with you. And I want to thank everyone who supported us to get us here, CTC Communications, Urban Block Media, but also all the supporters out there. You've been really generous in time and talking to us in the hallway about the things you'd like to hear. And so I think it's been great.
Absolutely. And please continue that conversation with us. And so, subscribe and give us feedback on what we've given you and what you've heard and what you're looking forward to in the future. So thank you again for joining us from GU ASCO. And we look forward to chatting you again soon on The View on GU. So for my co-host, Ali Khan Lalani, I'm Chris Wallace. I really appreciate your time.